I'm Michael McGinnis. It's my great pleasure to welcome you to IOM and NAS East or West. This is our facility on the West Coast, and we're delighted that we could take advantage of it. A number of our principal sponsor is here from the West Coast, and I'm going to introduce Peter Long in just a moment. And actually, I know that the roots of many of you who are participants here today have touched on the West Coast at one time or another. So welcome home for those of you who have those West Coast roots. Whether from the perspective of the growth in the science, which is extraordinary, or the potential of the technology revolution in which we're all participating, or the crushing burden of cost that looms before us in many ways, or the establishment of the legislative underpinnings for change, this is an extraordinarily dynamic period for health and health care. In a period of great fluidity, what can possibly be more important than anchoring our navigation around the stars that are most reliable indicators of the truest course, and that's your charge over the next couple of days. To draw deeply upon your experience, and the experience that's gathered in this room really is unparalleled, and the assembled material that's been pulled together by the steering committee and staff, and in your work over the next two-day period. You know, we in the IOM don't do anything less than 2 years. So this is a bit of an unnatural act for us, but it's the right one, it's the right time. Bring us as close as possible in those 2 days to the sort of celestial map, if you will, that'll help us chart and monitor the course of our journey toward better care, lower costs, and better health. And the achievement of each of those at every level, national, state, local, and institutional. I want to thank each of you for joining us because this is heavy lifting and these are busy times. And I know that it's not easy for you to carve out the time for this conversation, but it's absolutely vital. I'd like to begin with a special note of thanks to the Planning Committee. And I won't ask them to stand, but I will read through the list. Craig Jones is the chair, and we'll hear from Craig in just a moment. David Atkins, Maureen Bisognano, Michael Chernew, Diana Dooley, Julie Gerberding, Marjorie Ginsburg, Kate Goodrich, George Isham, Peter Margolis, Leo Morales, Judy Murphy, Sam Nussbaum, Pat Remington, Ed Sondick, David Stevens, Tom Valek, Ann Weiss, and Nancy Wilson. Thanks to all of the Planning Committee members for their work. The wisdom of the Planning Committee is clear, not only in looking at the agenda and the materials that have been assembled, but those of you who have been assembled by the Planning Committee to engage in this task. I won't belabor the identities of all of the stars that we have in this constellation. But we do have a representation that's truly extraordinary. We have in the front row here the head of healthcare quality for 300 million people in Carolyn Clancy. We have about 2/3 of the way back on the right-hand side the head of health for 30 million people here in the state of California, Diana Dooley. We have the head of the organization which serves as the intellectual beacon for the triple aim, which is our focus here, in Maureen, who is right over here. We have the head of the National Center for Health Statistics, and we have those who have shaped the rich set of discussions over the many years that have been undertaken on the measurement challenges and opportunities from philanthropy, from frontline healthcare organizations, from population health, and so on. We have the right group of people here in the room together. And it's a good thing, because this is a very difficult task. Our aim here is not to develop the final answer, but to come, as I mentioned, as close as we can to identifying the key opportunities, the key criteria, and the candidates that can be considered and taken on for additional work. It's my great pleasure to turn now to the individual who gave us this charge, Peter Long. Peter is the President and Chief Executive Officer of the Blue Shield of California Foundation. Peter came to the Blue Shield of California Foundation from the Kaiser Family Foundation and previously at the California Endowment. He has an extraordinarily interesting set of experiences that have shaped not only a fascinating career path, but put him in a position to really provide the kind of leadership that spans beyond the state of California, but to the nation as a whole in capturing the opportunities that lay before us. He's worked not only in this country, but in South Africa, where he served as a legislative analyst for the National Progressive Primary Healthcare Network in Cape Town. His training is at Harvard, at Hopkins, and at UCLA. And Peter, thank you very much, I think, for giving us this charge. Please join us and offer some comments.
Thank you very much and welcome. It's great to be here today. I thought what I would do, I think there's all of you, this is a workshop, and so it really is about the work that we're going to do together. So I thought I would just kind of how did we get here, give you a couple of minutes of how did we get here. You all know how we got here from the data side and from the metrics and all of that, but just in terms of literally how we came to this workshop. They invited me to a health affairs workshop about a year and a half ago, actually January of 2011, and there were 25 of the most amazing health organizations, and you know them all, Bellin, Virginia Mason, Vermont Blueprint for Health, community health centers in Colorado, and they, one after one after one, got up and presented about the amazing work that they were doing. Quad Health and Quad Graphics in the Midwest, and they got up and they said, we are achieving the triple aim, and they all have been working with IHI. They all had data. I mean, for those in the healthcare system, they all had data. It was verifiable. It was interesting. It was in all three domains. It was not just we think we've done better by our own standards. It was about healthcare outcomes. It was about lower cost, and it was about better care experience. And they made the mistake of asking me to comment because I'm a health services researcher by training. So I'll tell you my bias is I'm a health services researcher. And this was in the afternoon. And I got up and I said, this is amazing. But just to point this out, we have 25 different data sources. We have 25 different or more indicators of success. We have 25 different ways of whether it's self-reported or whether they hired an actuary or whether there was a government agency who came in and verified it. And I said, that is tremendous. That's an interesting accomplishment, but we're never going to have a healthcare system if this is the way we're moving forward, where our best and brightest organizations who we all think are doing the right thing, all committed to doing the right thing, and have done it very thoughtfully, are all using different metrics, are all using different standards, different methodologies, different definitions, we're sunk. And that was not a great, a couple of people came afterwards and said, wow, I can't believe you just got up and said that. And it's probably one, ignorance is bliss when you don't know any better to get up and, people ask a question, and I gave my honest answer. And that was an interesting experience. I think a few people said, well, you're onto something. So I came back and called Mike McGinnis and said, Mike, is it time to think about the triple aim as a policy framework? Is it time? It feels like CMS, Don Berwick at CMS is moving forward. The Center for Innovations are talking about the triple aim. Is there enough energy? Where are we in core metrics, and where are we on this journey to think about a national conversation? Can we have a systematic national conversation? Are we ready for that? And Mike's answer was sure. We're very ready, and I think you'll testify. Everyone, raise your hand if you read all the materials. Amazing. I am in a room of geeks. All right, good. It's, the nerd factor is very high in here, and that's good to know. But you can see from the materials, which are incredibly impressive, it's not for lack of indicators. It's not for lack of work. It's not for lack of people who have of goodwill and who have thought through these issues. What we really think, or what the sense of this workshop is, what's the distillation? What's the use? How do you take this to move forward? My read on it is, I think, and we work very deeply in California with safety net healthcare providers out here, trying to get them ready to be successful under health reform. And I have been amazingly impressed by community health centers, public hospitals, the folks serving the kind of most vulnerable citizens. They're up for the challenge. They're up for measurement. They're up for predictive analytics. They're up for data. They're up for even alternative payment methodology. I mean, they are up for the challenge of moving from volume to value. But when they look to us as a funder and other experts to say, so what is that? We need to know what the future is before we're going to go all into this new system. And if we're feeling that in California with our small subset of grantees, I can imagine big health systems across the country, public health systems, whether county or state, are saying, show us the money, show us the answers, and where we're all trying to go so that we can actually align and move forward collectively. And so we can't be, I think the time is ripe. And if we don't do it, I mean, I think there's an imperative now, if we don't do it and we do all of the other work around the Affordable Care Act implementation and don't finish this part, I think we'll have missed one of the biggest opportunities to consolidate and to actually create a healthcare system. The ACA does a great job in terms of moving people and in terms of moving money and consolidating those aspects, but it doesn't really do this. It doesn't create a collective set of measures that we all can agree upon, standards, definitions, so that we all can kind of know where we're going. One thing I would observe, and why I thought the triple aim is so compelling to me, is I inherited, when I came to the Blue Shield of California Foundation, a technology assessment forum. So I got a foundation and a technology assessment forum that have been around for 70 years. And one of the things in observing that, it's a great organization. UCSF does our analysis. We have public process. We've done everything right. But they didn't take cost. They haven't taken cost and value into the equation. And so they look at efficacy, they look at safety, and they do excellent research, have public comment. And the thing that tipped me off that we've got to do more, we've got to think about them all together, is every time they approve a technology, there's a press release within 24 hours, touting CTAF, and CTAF has approved it. Every time they deny one, there are rebuttals, there's calls for another review. You didn't quite get the right evidence. There's a new study from Stockholm that has great data. And so it tells me that unless you actually can solve the healthcare outcomes as well as the cost-value equation together, that we're not going to actually drive systems change. Let me conclude, and foundations always have bias, and they always have, I just want to, as a health services researcher, we are a California-based foundation. I'm a health services researcher. Our goal is to stimulate this conversation. We don't have an agenda that we're driving towards. We want the Blue Shield of California Foundation set of metrics. We're not going to have our own task force. We don't have any of those agendas. We think this is an opportunity to start the conversation, to seed it, and that's why we thought IOM, in a sense, what better convener than the IOM, who's neutral, has the ability to take something forward and to kind of reach a broad consensus. So that for all those thinking, why is Blue Shield of California Foundation involved? We have an entrepreneurial CEO who's a health services researcher by training, who wants to contribute to the larger conversation about our healthcare system. There's no more, that's full transparency in the funding, so you all can get about the work of what we're here to do today. So I'd like to welcome you, wish you luck in the next day and a half. I mean, I think this is the right set of people. This is the right time. These are the right resources. As a funder, I couldn't be more pleased of the group brought together, of the conversation we're about to have. And as a health services researcher, I'm ready to jump right in with you. So thanks very much, and I look forward to the next 2 days.
Thank you, Peter, for the perfect charge to us. And it's clear that the enthusiasm and commitment that Peter brings to this activity should set the tone for our discussions throughout the course of the 2 days. I want to introduce Craig Jones now. Before doing that, let me just underscore three things that were prompted by listening to Peter's comments. First is that we do have the geeks in the room. We do have folks who have spent much of their career examining and assessing the kinds of measures that are most important, that are the truest indication of better care, better outcomes, lower costs, and better health. But we also have the practitioners in the room. We have the individuals who are dependent upon the right measures in order to set program direction and monitor and ensure accountability for the appropriate use of resources, public and private, to achieve that triple aim. And the third point that I'll make is just that we're not setting you out on a totally impossible task. This is heavy lifting. I want to underscore the fact that we want you to get as close as possible to the set of metrics that you think can work. But we realize that there has to be a follow-on, more detailed assessment if, in fact, this is going to be usable at the national, state, local, and institutional level. So we will, if you make enough progress, we will then take on that more targeted task to refine what you've done. The jury's out as to whether we'll do that, but we're committed to doing it if, in fact, the kind of progress that this group of all groups has the potential to make is, in fact, made. It's a pleasure now for me to introduce Craig Jones, who's the chair of the Planning Committee. Craig is the director of the Vermont Blueprint for Health. He's a Californian. He was trained just down the road here at UCSD and then went to University of Texas for his medical training and came back to California to get his pediatric training, where he stayed on in the faculty at the University of Southern California and headed their pediatric allergy and immunology work. And that work naturally took him outside the clinic doors into the community to try to fashion the kind of initiative that was fundamentally important to improve the health of the children that he was concerned about. As these things tend to do, one thing led to another, and he became focused on the broader social policies and social opportunities that are at hand if we can, in fact, marshal the energies of a community and a society around measurable progress on key dimensions, and that led him to move to Vermont, where he serves as the director, as I mentioned, of the Blueprint for Health, and is in charge there of mobilizing the healthcare community, the community citizenry as a whole, and the policy leadership in the state of Vermont to improve the health of all Vermonters. Craig, thank you very much for what you've done for the Planning Committee, and please let me invite you to the podium to give us our charge.
First off, Michael, thank you very much for the introduction. I really appreciate it. And I can't thank both you and Peter enough for the chance to be part of this whole initiative. It's an imperative from my perspective, and I hope the day's discussions will help frame out why that is for many of us and maybe all of us in the room. And I just, before even starting off, want to acknowledge the work of the Planning Committee. It's been somewhat overwhelming to be on the phone regularly with the group of people who have been involved in trying to think through how to put this first work group together. It's an incredible group of people, and I just want to thank each and every one of you for the contributions you made, and then particularly the IOM team, Michael's team, how they took that and put together the materials, the documents, the agenda that you have. They did an incredible job, and I just want to take a moment and thank the IOM team for the work that they've done. So let me just make a few brief remarks and then we'll jump right in, because we have a lot to do and we do have an ambitious goal for today. And the aim, really, the overarching aim for this workshop is to really move the state of measurement forward. and particularly a focus on how core measures can move the state of measurement forward across the country, the importance of core measures for that effort. We've heard already a lot about the context and the array of healthcare reform initiatives that are going on across the country, and more they're not only being called healthcare but health initiatives, health services initiatives. The thinking across the country is changing, and it's fantastic. How many of these initiatives are in one way or another framing their goals and objectives around the triple aims? It's taken a life in health services reforms across the country. It's a fantastic time and opportunity to begin to really think about the vision of a learning health system, which the IOM has propelled and put out front and center. The chances, the opportunities are really unique. That said, for those involved deeply in a lot of the healthcare reform initiatives that are going on, the ability to implement the digital infrastructure, the measurement systems that can drive a learning health system have emerged as one of the greatest challenges. And that you can hear coast to coast and almost anywhere you go. And I believe that's the drive that Peter responded to in his comments as he opened it up. So the goal of this meeting is fairly straightforward, challenging but straightforward. We're going to explore the vision for the use of core metrics across the country, put a context to this, how they may be used, how they are being used in certain circumstances, examples of where core measures are being used, what are the challenges to implementing and using core metrics, and then ideally, and these are where the breakout sessions become critical, come away with a clear sense of some categories that are essential for measuring progress against the triple aims, and then ideally a set of example measures within each of those categories. And as Michael pointed out, nothing's done. There doesn't have to be a finished set of measures. Nothing ever will be finished. But are there some basic examples that people can coalesce around that can help drive the agenda forward and put some systemness, some national movement toward using core measures to drive a learning health system in America? That's really the challenge. That's the opportunity of the meeting. As you know, this is a workshop. It's dynamic. It's going to be interactive, less about didactics and more about discussion. And the real essential productivity hopefully will take place in the breakout sessions. We'll have a chance to ideally explore some example measures to meet the triple aims and for each of the major components of that. You've already heard a reference to the background materials, and again, just want to thank the team for putting them together. There's quite a bit of reference material in there to help drive this discussion, examples of measures, the categories, where they originate from. Quite a bit of information. There's other reference material on the back table in the corner over there if anybody wants to, for whatever reason, look up some of the examples that are referenced in these materials. There's some reference materials back there. With that, let's go ahead and jump right into starting off our first session. And again, thank the Planning Committee for orienting the agenda and the context. The very first session is to hopefully lay out a vision, to give some examples, and then most importantly, drive a discussion. So we're going to have two wonderful speakers to help start this off, present a vision of how measures are being used across the country, the challenges, how measures can work at different levels, ranging all the way from individual patient care and rolling up to organizations, regions, states, maybe nationally. And we'll set the table, set the context. We're going to have two 20-minute presentations. We'll take some clarifying questions in between the speakers, but then leave a good amount of time after the speakers to really drive a discussion and start the day off. So let me first introduce our two speakers. First, Maureen Bisognano, the President and Chief Executive Officer for the Institute for Healthcare Improvement. And Maureen is also an instructor of medicine at Harvard Medical School and a research associate at Brigham and Women's Hospital. Serves on a number of boards and she's an elected member of the Institute of Medicine. Maybe most importantly, Maureen began her career in the front lines as a nurse at Quincy Hospital in Massachusetts and has overseen healthcare delivery organizations both as a COO and a CEO, and she brings a wealth of experience and will really help set the context for the day. And following Maureen is George Isham, Senior Advisor to HealthPartners. He's responsible for working with the Board of Directors and the Senior Management Team on improving health and healthcare quality for patients and for the whole community. He serves as a Senior Fellow at the HealthPartners Research Foundation and is responsible for helping progress at the intersection of population health research and public policy. George was a founding board member for the Institute for Clinical Systems Improvement, which is a collaborative of medical groups and health plans that is improving AAA outcomes across Minnesota. And he also works on a variety of measurement-related initiatives and currently co-chairs the National Quality Forum convened Measurement Application Partnership and chairs the NCQA's Clinical Program Committee and is serving on the NCQA Committee on Performance Measurement. He also chairs the CMS Technical Expert Panel for assessing the impact of quality measures, among other activities. So these are two wonderful people to help frame today's discussion, provide us the vision to start off with, and I'm looking forward to an incredible workshop. Thank you all for attending. It's a wonderful opportunity we have. So let me first bring Maureen up to start the day off and look forward to the discussions.
Well, thank you. I'm delighted to be here with you because I think this topic is so incredibly important. I'm the opposite of a measurement geek, but I do have the great pleasure of being on the front lines in healthcare organizations around the country virtually every week, and I see the struggles that this committee can actually work on solving. I see the waste in the system. I see people working off measurement that perhaps isn't going to add any value, so I'm really excited about this work here. What I thought I would do is kind of go back and talk a little bit about the history of the Triple Aim and some of the lessons that we've learned over the last 6 or 7 years as the Triple Aim came to be. Back in 2006, we had a small group of folks at IHI who began to talk about what was the aim, what was the goal of the healthcare system, and should it be healthcare or should it be health? And we began to go around the country, talk to leaders, and we had increasing confidence because we had been working on a project called Pursuing Perfection with some pioneering organizations around the world. And we had some success with the 100,000 Lives campaign and the 5 Million Lives campaign. So we began to see that if you set an aim and everybody kind of comes together around an aim, that you can actually make national progress. So we were excited by that. But as we talked with system leaders around the country, we found this incredible diversity of what the aim should be. Some were talking about cost, and perhaps not in the same way we're going to be talking about cost today. Many were talking about the experience of care and the IOM dimensions of quality. Very few within the healthcare system were talking about health. And so we had to kind of go to all different parts of the country in order to figure out what a goal might be. But as we did, we began to come up with this idea that perhaps we should set an aim and look at what the triple aim might be. We had the Commonwealth Fund data, we had the Dartmouth Atlas, and research studies were very clear on the gaps between the U.S. and other countries and across the U.S. So as we dug deeply into looking at these gaps, it led to the development of what we began to call the triple aim. It was, how can we simultaneously engage people to work on the health of a population, we started off with, to work on the experience of care, and to work on cost per capita. And then I'll come back in a minute to talk about why we put that black dot in the middle of the triple aim diagram. But we reached out and we said, is there anybody out there that wants to take on this aim with us? And we had 15 pioneering organizations, many in this room, who joined up to say, even though there's no business case for this, even though I don't necessarily see this as my role, I want to join in a learning community and see whether or not having the bold aim drives a different portfolio of work. So we came together, this group, and began to meet from time to time, sharing and beginning the very early work of measurement. The lessons from the early days were how critical that black dot in the middle was, because nobody felt like they were serving as the role of what we came to call the integrator. People would say, well, this is my corner of the triple aim, or I'll take these two. But it was a rare organization even in the world, even when we worked in Sweden and in England, where you would think that somebody would say, that's my job, it was a rare organization in the world that put themselves. So we drew the black dot in the middle and said, if we're going to indeed accomplish the triple aim, we need to create a role of an integrator. And we've learned a great deal about that over these last years. I'll come back to some lessons in a minute. We also learned that you have to identify a population. We started with a population, and you'll see how we've migrated to the population. But in the early days, people didn't know who lived in their community, and they said, I only take care of certain people, or I take care of who comes in, not I don't feel responsibility for them when they go home. And so all these fragmented pieces of the system emerged when we began to say a population. And we found that many of the pioneers, as they focused in on a population, began to see that the triple aim could be within their grasp. And then we began with some early set of measures, but as Michael was saying, they were all over the place. Peter provoked us at that meeting, I remember it well, by asking that question, because everybody was measuring something different. And we found that in the early days, people really even had a challenge figuring out how they could measure around all of the aspects of the triple aim. Then once they got the measures down, they realized how complicated it was going to be to build a portfolio of projects that could actually move the triple aim. So we began building driver diagrams and thinking about all the work you would need to do to move those metrics. We began to think about pace and tempo and how do you set constraints on where to put the resources. So an early example, Peter mentioned QuadMed. QuadMed is the second largest printing company in the United States. Does anybody know them? A couple of you, really and truly everybody in this room knows them because they're the ones that will put the Williams-Sonoma catalog in your mailbox when you get home. Everybody touches Quad Graphics. And so it's the second largest printing company in the world, and they joined the triple aim because the CEO was so frustrated that he could control any metric, any aspect of cost or quality in his production system except healthcare. And so he called his brother, who was a physician, back to Wisconsin, and they set up a small organization within the printing company called QuadMed. And they created a new model built on the triple aim. They used the triple aim to build what came to be called a primary patient-centered medical home. But their results were pretty dramatic. What you can see is that the model that they built is quite different. It is the physicians are paid on outcomes and satisfaction, not productivity. They built in data systems that allowed them to work across the whole patient population. It's a very broad-based view. And they're a union shop, so they had to kind of build a system that was attractive to the employees to have them come and get their care on site. As they started, though, what you see is that their clinical outcomes improved quicker than other places, and their costs reduced more quickly than other places. They ended up with really quite a fantastic model of care. But the thing I think that was most interesting for me was when I first began to visit with their leaders, is I saw this map, and I said, what's this map? And they said, oh, those are the other companies in the United States that are now hiring the printing company to produce healthcare for their employees. And that was a breathtaking moment for me when I realized that Quad Graphics was now providing healthcare to other companies, including beer companies and other companies, that breweries that had nothing to do with their location and had nothing to do with their population. But when you build a model around the triple aim and you can produce better health, which is productivity, presenteeism, and joy in work, and you make care convenient and local at the site of work, and you work on cost per capita by getting all of the right incentives in place, you can produce something that's dramatically different and is competing with all of us in the room who see ourselves in the healthcare system. So it's one example, and as we ran that collaborative, we began to learn more lessons about the triple aim and especially about measurement. We realized that we need measurement over time, that we needed to understand measurement for learning and not for incentives. And I'll tell you, I am really worried about the current way that we're building the linkages between measurement and incentives. What I'm seeing is, in a lot of ways, us migrate away from the triple aim because people become so focused on local measurement that they're designing care systems that don't look anything like quad graphics. So I am really excited about us putting a different stake in the ground here. We need a learning system. You know, as Peter was saying, when we had all those folks in the room in DC, every one of them was a unique and vibrant experience. But unless we call them together, there's no way that they naturally can learn. I feel like, in a sense, that's IHI's role. But we really need to put the learning out there so that we can get quicker, get better much more quickly. We need clarity on measuring progress at the outcomes process and at the population level and create those linkages. And one of the biggest lessons we learned was how critical the role of governance was, because that little black dot looks nice and clear, but nobody owns the integration. There really isn't even a healthcare system we can find in the United States that owns every single piece of that. So it becomes a governance question, not a management question. So in 2010, we took all of those lessons and said we need the next generation of the triple aim. And this was as a result of the potential impact of ACA, all the driving incentive changes, looking at cost pressures in the communities. And so we began to expand the view. In the early models of the triple aim, we were working within the current healthcare system. And we realized that we weren't going to get there by confining our work to the organizations that call themselves hospitals or primary care centers or safety net centers, that we needed to go outside the walls of the hospital if we're going to actually move the triple aim. So again, one quick example here is that we started working in Shelby County in Tennessee and in Memphis. And in the early days of our work there, we were working with all of the healthcare leaders, the CEOs of all the hospitals, the Commissioner of Public Health, the school nurses and the like. But what we realized is that the metrics weren't moving because we were stuck in the walls and the confines of the health system. So we then took all the data from the Dartmouth Atlas and the HRR and began to look at what are the real clinical problems here and who might be able to help. And as we expanded our vision, we began to see incredible potential in working with churches and working outside of the defined healthcare system. In Memphis, 95% of the population belongs to a church. And I remember sitting around a table where we had moved from all of the healthcare leaders being in the room to including a much broader definition: the mayor of Shelby County, the mayor of Memphis, the ministers, and the folks who were running a lot of the healthcare system through the church network for the uninsured in Memphis. And I remember sitting there and looking at the one of the ministers who said, you know, you're worried about diabetes, you're worried about hypertension, you don't understand the disconnect between the population and the healthcare system. And one of the ministers said to the physicians, you see these patients twice a year for 15 minutes, and you expect to change diabetes outcomes. I see them twice a week for 2 hours. So he said, I'll take diabetes, and you guys can work on something else. And it changed the whole dynamic, because he does see all these patients with diabetes twice a week when they come in for church. And he started, when they come in for their dinners, to serve them on small plates and to serve them healthy food. And he changed his sermons to say that your health is a blessing, that it's that your health is sanctity, and if you want to be a member of the church, if you want to be a good mother or a good son, you've got to take care of yourself. And then the ministers started getting healthier, which kind of brought together the whole community in a very different way. It became every single week what you talked about in the way of life, not an interval of visit every 6 months. And it engaged all of the aspects of health. It was really kind of a great vision, I think, of the triple aim. So what we're starting to see there is a different way to define healthcare. When you look at the drivers that we're seeing for getting patients into hypertension treatment, for getting young women to engage in the healthcare system because they never used to come, and they're the ones that lever the rest of the family into the system. Congregational health promotion navigation and integration, those don't typically fall within the purview. So it really does demonstrate, I think, the governance challenge of bringing together a different group of people and then engaging them in a different set of activities with a population in mind, with specific interventions in mind, and then moving the lessons that you learn from the small groups up to the whole. So there, in that second phase, we learned some new lessons about measurement. We learned that, as an example, we need to think about value in a very different way. And Matt Stiefel will talk a little bit later on today about some of these different definitions. But the white paper that we've referenced in the materials talks about it in this way. And it says value is the optimization of the triple aim. So we've got to first understand the population and then optimize all three elements of the triple aim in order to get to value. So if we're moving from volume to value, it's not possible, in my view, to say I'm going to move from volume to value in this piece of the triple aim or that. To me, it really does belong to the role of the integrator. Matt's defined the combination of per capita costs and experience as efficiency. So can we get the right activities and look at costs so that we're not producing excess testing or unnecessary procedures? He says the combination of population health and experience measures effectiveness. And then finally, when we combine all of these together, it's where we can measure value. So as I wrap up my comments, I wanted to, first of all, give you a little bit of history about how we got here, a little bit of my view on where the challenges remain at measuring the triple aim at a community level, at a population level. And yet, as I've been reading all of these papers, I want to make sure that we don't emphasize the population at the expense of the individual. And so it's value here and it's values here. And we really can't afford, I think, to move away from the values that we're providing in interacting with an individual patient in service of a population as a whole. We will have lost it if we get to that kind of system. So as I often do, I will end my remarks this morning by bringing us back to an individual patient and describing what the triple aim looks like for an individual patient. Because I think if we keep Gilbert in mind, we will migrate to the right set of metrics and measures, core metrics. Gilbert Salinas is a patient that I met a couple years ago. And if you come to the IHI annual forum, if you came last year, you may have met Gilbert. Gilbert is the co-chair of the forum this year, next week in Orlando. But Gilbert is a patient who I think is a visual representation of what the healthcare system needs to be. He is right now 39 years old, and some years ago when he was a teenager, he was playing with a handgun in LA and accidentally shot himself in the spine, and the bullet is still lodged in his spine, and he's been paralyzed now for quite some time. And when I was interviewing Gilbert, I was asking him, tell me about your interactions with the healthcare system. And he said, it is fantastic. He said, my doctors and nurses, they know me. It's not like they say, what's your name, who's your doctor? When I walk in, he says that he walks. He says, when I walk into the office, he say, hey, Gilbert, how's your mother? And everybody knows me. And he said, they know my needs in the broadest sense. They know my fears. They know my physical needs. And they're very responsive. He said with technology now, by the time he gets to his car and he's folding up his wheelchair, he said that his cell phone will ring and all his lab tests will be on his cell phone. And he said when he gets home, he can go onto his patient portal and he can see a visit summary that includes occupational health merged with his physician orders, all of the summaries of his tests, and his plan for what he's supposed to do between now and the next visit. So he had lots of wonderful things to say about the healthcare system. As I was talking with him, I said, Gilbert, tell me about your wheelchair. And he said, it's the latest technology, it's hydraulic, it's very light. And I said, does anything ever go wrong? And I don't even know why I asked that question. but he said, only when I get a flat tire. Now, I've been in healthcare for almost 40 years, and I can honestly say that I never thought about a patient getting a flat tire in a wheelchair. It never crossed my mind. And so I said to him, tell me what happens when you get a flat tire. And he said, I call my doctor, I tell him I got a flat tire, the doctor writes a prescription for a replacement tire, it goes to the durable medical equipment department, they put it out to bid, when the tire replacement comes in, the receptionist calls me, and then I come in and get my tire replaced. And I said, Gilbert, how long does that take? And he said, 3 weeks. And I said, Gilbert, what happens in the 3 weeks? And he said, you know, Maureen, you know when you get a sprained ankle and you overcompensate on the other leg and then it throws out all your muscles? He said, well, it throws out all my muscles because I have to, for 3 weeks, pull really hard on the flat tire. And when I'm pulling on the flat tire, it throws the muscles in my back out because the bullet's still lodged, which means I need to take pain medication, which means I can't work. And so to him, health is work. He describes the healthcare system, but to him, health is work. Health is not relying on pain medication. One of the nurses in the audience jumped up and said, Gilbert, I got a flat tire last night on my way home. I called roadside assistance. I was fixed and driving away in an hour. We can do that for you. And I said, no, you can't, because that's the way we work. We fix it for one. We fix it for Gilbert because he's so lovable. Or we fix it for somebody who complains a lot. But we don't fix it for all. So I said, this system will fix it for all, because that's how we're going to get Gilbert to work. And then he described, as an example, the absenteeism that he faces when he gets urinary tract infections. And I said, why do you get urinary tract infections? And he said he has to catheterize himself 4 or 5 times a day. He works in a hospital. He goes into the men's room and he catheterizes himself. And then he describes how he comes out and he washes the catheter in the sink. And I said, why do you do that? And he said, Medicare rules are that you can only get so many catheters a week. And I did the math. And he said, I don't have enough catheters, so I have to wash them. And so he periodically gets urinary tract infections. And so I said to him, what happens? And he said, well, when I walk into the pharmacy, they have a shelf called Gilbert Cipro, because he so frequently gets the infections that they park a little place of Cipro for him on the shelf. And his doctor was in the audience, jumped up, Gilbert, I'll get you some catheters. I said, no, you can't. You've got to fix it for the whole. But I said, have you talked to your doctor about it? And he said, yes. He said, the doctor said there is another way. I could microwave them. So we started going to the employee cafeteria, but that really freaked out the rest of the guys where he works. But several times a year, on average, he's hospitalized. He's not working. And so what happened was nobody saw the whole of Gilbert's year. They saw the interaction and how quickly could we get him the Cipro. They saw how quickly could we get him a tire replacement. But to look at the whole of Gilbert as the triple aim means we need to get Gilbert to work. That's his health. We need to understand the experience of care. And right now it's fragmented across a wonderful system, but it's fragmented, and we need to put that together in order to produce the better experience of care. And when we do those things, the cost of Gilbert's care is going to plummet because he's not going to be on Cipro and he's not going to be hospitalized. So will he be more productive in society. So I am really excited about this work these days. To me, what I'm seeing in the field is that the design of core metrics is critical for all these perspectives. I work with great innovative organizations, but they can't do this work by themselves. One, they're not developing the same metrics, and they don't have the experience of the people in this room. They need us to come together and offer this support to them. I think simplicity and comparability are going to be key for national learning. And they've got to be actionable, and they've got to connect to values as well as value. So thank you very much.
Should we see if there's a couple clarifying questions, and then we'll move into the second speaker?
Carolyn?
I had to ask one. That was magnificent. Thank you. Wait. So I have to say the nice part first. That was magnificent. Thank you.
Thank you.
Can you just say a couple of words about the integrator? I mean, sitting in Washington, D.C. area, either everybody's an integrator or nobody's an integrator, and I'm trying to imagine what this looks like.
It's a great question because we haven't found any two integrators that look alike either. So our belief is that anybody can be an integrator, but it's stepping into the job of governance. And so, as an example, in Memphis, there's a wonderful group that's come together called the Memphis Common Table. In Columbia, South Carolina, there's a group called Healthy Columbia. And it's representatives from various organizations who've come together. It needs strong governance, so it needs somebody to be named as head. It needs an independent structure or a way to measure that brings people together. So it's actually a small but vital additional infrastructure that creates this coalition. Now, theoretically, HealthPartners can be an integrator. Kaiser Permanente can be an integrator. They perhaps are in some populations of their patients now and perhaps not in others, are moving that way. But the role is to see the broad-based needs and to work on all three of the aspects of it. So I don't think it's an easily defined role at the moment, but we're seeing really success stories emerge. Thanks. Yes?
In some of the materials it talked about the integrator being independent. I wasn't quite sure independent of what.
Well, so in Memphis, as an example, the Memphis Common Table is a group that came together. It's not owned by any one of the academic medical centers, nor government, nor the public health department. It's an independent organization that has a little bit more clout because of that, a little bit more attention to the agendas of the whole. And I don't think it necessarily will end up that all integrators are independent, but at the moment, we're finding that that kind of attention to all three areas is requiring an independence.
So let's take one more clarifying question, then we can move into the next speaker.
David?
Hi, Maureen. Thanks. I just had something for you to clarify a little bit for me about the population versus the individual, and you were saying that we've lost it if we put too much emphasis on population. Can you explain that a little bit? Because an example from Gilbert, it seems like you were talking about the population. You want to know about all people in the community that have a flat tire, for example.
Yes.
So I wasn't sure what you meant by that, and would like to know because I think it should inform our discussion.
Thank you, David. So my worry is that if we only seek metrics that are at the population level, that we'll never get to understand what a flat tire means to a patient. That we'll be looking at hemoglobin A1Cs, and we'll be looking at blood pressure readings, and we're not going to understand the meaning of those metrics to a patient. So it's not that they aren't important and critical. I just think the more that we can link them back to patient stories, the more that we'll understand. You may have heard me say this a million times, but my belief is, working with Susan Edgman-Levitin up at Mass General, is that we've built a system that I call what's the matter medicine. You come into my office and I say, what's the matter? My blood pressure's up, I have pain in my right knee, and then I take care of that. And it's all what's the matter medicine. And I think we need to move to what matters to you medicine. And if all the metrics are linked to money, then I worry that we'll move away from what matters to you. Thank you.
Maureen, thank you very much. Let's go ahead and jump into our second opening discussion. And George, look forward to your comments.
So, thank you very much. I really appreciate this opportunity, and I am very humbled by the fact that I've accompanied Maureen. Maureen was very kind to visit us at HealthPartners a couple weeks ago. Very inspirational to our board of directors and our leadership team. IHI has been very important to us over the period of time back in 2005 when we were working on our periodic 5-year plan. Tom Nolan came to visit us and made the observation to our board that we were one of the few organizations, because we had financing, care delivery, and so forth, that could work on, wasn't quite the triple aim at that point, but it was essentially the triple aim. And that set our organization on a path to think about that and adopt that framework. It's slightly different than the national framework, but we've adopted that framework. We're working on it ever since. So thank you, Maureen, and thank you to IHI. Also appreciate the invitation from the IOM to be part of this and the charge to the committee. I don't think I've struggled as much with what to say in this talk as I have with a talk in a long time. So I'm going to struggle a lot with you today in terms of this issue of the whole population and the individual patient. And if this doesn't turn out okay, it's typical of many talks that I do where I'm struggling with something. But I hope it'll help us with our overall conversation. So with that, let me move forward. And how do I move this forward? Here we go. So I want to start with insects. So I'm thinking about ants because ants are interesting creatures. They've got, they lay down apparently pheromones that can help them figure out how to get food. They can make little noises with their mandibles to communicate with each other. In their eyes, they've got like these little refractive things that can help them navigate the food and so on and so forth. But aside from the queen bee, or the queen ant, who's the chief or the head of the whole thing, she's only the head for reproductive purposes. There's no actual direction. There's no CEO in ants, apparently. And so the other thing is that ants can achieve tremendous organization. This is a plaster cast of a colony that I found on the internet. And apparently they can make their colonies over several hundred miles and have actually colonies that I understand are made up of millions and billions of individuals, all sort of doing their thing. This particular view is an ant milking an aphid for a honey kind of material, and they live in symbiosis. So interesting example from nature of a very complicated system, complex system. And so I was at another IOM meeting in New York City recently. Actually, the Health Literacy Roundtable had a meeting in New York City, and I was flying out of New York City on a beautiful day in a window seat looking down on the city. And this is actually, if you fly out of LaGuardia, you get the other view of New York City. This, I think, is looking north. But I was struck by how New York City is not really something that was envisioned or emerged. It's emerged as a vital place. I had 2 days there that were just wonderful in experiencing the culture of that city versus the culture of where I live. And it's, you know, it's really exciting kind of place to be. But it didn't come because there was a national committee or a CEO direction. I mean, New York is New York, and it's emerged. So I began to think about complex and complexity science, which I'm not an expert in at all. But I'm reminded of what I was introduced to a long time ago about complexity science. And this is from a paper from Paul Plesick about one definition for a complex adaptive system. And then a number of the aspects of it from this paper that he wrote in the British Medical Journal with others a number of years ago. So, you know, these systems evolve. Both the agents within them as well as the system. There are systems embedded within systems, and they co-evolve. And this continues that list. Tension and paradox. We were just talking about tension and paradox, and I think you gave an excellent example of the tension between optimizing population metrics and cost metrics versus what matters to people. And there's a tension there around how to get that right. And there are a lot of other tensions and paradox. Interaction leads to continually emerging novel behavior. There's nonlinearity here, inherent unpredictability and inherent pattern attractor behavior, which I don't fully understand, and then inherent self-organization through simply locally applied rules. And so I think there's, at this level of generality, there's danger in this work in terms of over-specifying the measures at different levels and over-regulating, because the population health system is inherently a complex adaptive system. You already had Maureen and some of the folks that have introduced this session already indicate to us that there's no single CEO for the system. There's no single direction for the system. We like to think sometimes that some of the national agencies or organizations are providing that direction, but even the federal government is fragmented on this across the way. And so the public health and the private health systems are quite separate. They represent two subsystems. And even within those public and private systems, they're fragmented both by geography and local. And a number of IOM reports have addressed that on the public health side, which I've been part of some of those and read a number of others. But that has been, quite the case. It's very obvious that the private healthcare system is fragmented. It is so fragmented and although the current tendency through the ACA is to form ACOs and organizations, those organizations are still quite separate, and they're novel, they're growing up, and so forth. So this is a system. So actually, Paul offered in the Crossing the Quality Chasm in the appendix. Who reads the appendix? And I forgot, I don't know, my thumb-eared copy of this report, I don't think I've ever really actually read this appendix until just recently. But he offers some opportunities. There are some key elements in an approach. And they include using biological metaphors to guide thinking rather than engineering metaphors. In other words, farmers versus engineers. What conditions will be the right conditions that'll likely bring in a good crop, but won't ensure it, and won't engineer a good crop, but likely bring it in because of the weather and the other factors that farmers must face. Create conditions in which the system can evolve naturally over time. And I think that's something we need to be thinking about, is what conditions does the system need to have so that it can evolve toward our objectives of the three aims and the sub-aims that we decide underneath it. Provide simple rules and minimum specifications. Our tendency in this day and age will be to overregulate and overspecify for some aspects of the system and to ignore entirely other critical aspects of the system because of our training in medicine and because many of us are trained in classic research, sort of research that's based on clinical trials and so forth, where the rules are quite different than the kind of thinking that's needed for these kinds of systems. Set forth a good enough vision and create a wide space for natural creativity to emerge from local actions within the system. So what is a good enough vision for this? And I think that's a question that bears some real thinking. So Paul, thank you, Paul. I wish I'd read this more carefully along the way in my thumb-eared copy of the Crossing the Quality Chasm. And for me anyway, I don't know about the rest of you, I'm a slow learner. I have to read things about 5 times. But I think given this conversation and challenge, these sets of observations from years ago now have particular relevance to the task that we're faced with over the next couple days. So Tom Kotke and our organization, Nico, who's here, Nico Pronk, who's sitting over there from our organization, and myself, earlier this year wrote 5 simple rules, sort of observations, actually picking up on Paul Plesik's challenge that he made many, many years ago for the rules to be identified. We thought we'd we thought we would be bold enough to make the suggestion of 5 rules to sort of follow up on his challenge. And I've said 5 simple rules rather than 5 simple rules for healthcare, because we actually wrote this for healthcare. But as I looked at them with this charge in mind, I thought, well, maybe they'll be a good starting point for this conversation too. So the stakeholders should agree on a set of mutually measurable goals for the system. And so we've got the triple aim, and we've got some sub-goals underneath that, at least as from the national quality strategy. But we really need to nail that down, and we really need to figure out what those goals and sub-goals really look like. The extent to which goals are being achieved is reported to the public. And we have a lot of data. And actually, I've struggled with this, as I imagine a number of you in this room have struggled with this, to try to put together pictures of our local area and so forth. But you have to draw the data from everywhere. And depending upon how methodologically challenged you are, and I've always been in senior enough management positions that I'm very methodologically challenged, I mean, it's very hard to do. And we need to think about making that easier and that the kind of data more available and then reporting it, figuring out a system to actually report where you are. Resources are available to achieve these goals, and that is no small problem. I'll comment further. later. Stakeholder incentives, imperatives, and sanctions are aligned with the agreed upon health system goals. That's an issue that actually David Kindig and I have been thinking about more recently. And leaders of all stakeholders endorse, promote, and honor the agreed upon health systems goals. And I think that obviously is a challenge as well, because we don't quite have a picture of how big the bread box is, how many compartments it has, what the rules are. The definitions aren't clear. I know Steve Teutsch, you and your partner in this recent paper you did for the NQF pointed out the fact that definitions are a critical issue. So we do need to try to create the conditions where those goals can be endorsed. So I humbly offer these to you. You can tear them apart and build them out and so forth, but those are a couple of ideas. So the triple aim itself, and Maureen, you introduced it, and now it's the National Quality Strategy as well. So what is the opportunity for improvement in health, for cost, for experience of care? What's the opportunity in the United States as a whole, in the states, in specific communities? What's the opportunity by public subunits and private subunits responsible for health and experience of care at each of these levels? And we begin to get to the issue of the gradation between large and small. And I am just captivated by these continual editions of the OECD chart in terms of cost versus life expectancy, per capita spending versus life expectancy for the country. And what I like to do is France, France is an interesting country. They drink a lot of wine. I love red wine myself. I like their breakfasts with their, the great rolls with the butter you shouldn't be eating and so forth. And yet, they've got 3 years of life expectancy, better than we do. And it's not because of the health behaviors that I just referred to rather comically, but it's because of the way they're organized. And then they've also, if you look on the cost dimension, it's just about now $4,000 per capita, I guess is the difference in this latest report. In this latest edition of the OECD report, the United States, in terms of MRIs, has more per capita than France, and CTs too. In terms of screening, we actually do better than France in terms of screening for cervical cancer, but in terms of 5-year survival rates, for some reason they do better than we do. Their data is not complete, so I don't know if that's entirely comparable. And then in terms of chronic disease, this is asthma, hospital admissions for asthma, an indicator at the very gross level of quality of care, and health of the United States falls down in an unfavorable position relative to France. And so it leads me to a couple of conclusions. One, the healthcare system in our country is multiple systems, and they're sub-optimized to maximize the subsystem. So the healthcare system, for reasons that we're all quite familiar with in terms of fee-for-service medicine and so forth, is sub-optimized to spend a lot of that money, and it's not being applied evenly across the population to get the result we want in terms of outcomes. And so this committee, which I was a member of, this IOM committee for the public's health, investing in a healthier future, recommended that the Secretary of HHS should set national goals for life expectancy and per capita health expenditures that by 2030 bring the U.S. to the average levels among other wealthy countries. I think there are two reasons to begin to set specific targets. There are a couple of reasons to think about this. One, we need to stimulate innovation, and I know of no better way to do that, whether it's policy innovation and so forth, than to think about how we need to get to someplace. So if we go back to that OECD chart, and we think about that $2,000 per capita, and we want to think about how we're more competitive as a country with respect to jobs, military preparedness, health of the country overall, and so forth, get more value for the dollar, we're going to have to do better than incremental thinking. And I think that that can be stimulated by setting a target. Likewise, I think we ought to have a challenge in terms of that life expectancy figure as a nation. And then we ought to have our smart people, and I'm not one of them, figure out how that's broken down by state, figure out how that's broken down by community, figure out which parts of our country need technical and other assistance. I mean, we can't forever ignore the fact that the country is not one single country with respect to the way it behaves. It needs to be dealt with by region and by state. And there needs to be far more attention called to that kind of issue at the national level than is current with our current data and current policy discussions. So the triple aim itself, and David Kindig has written this in his blog, really asking the question about how the components of the triple aim relate to the broader issue and determinants of health that build to the outcomes of health. And basically, he points out that experience of care and per capita cost really, to a large extent, belong to healthcare. And the population level box is not clearly defined in terms of the determinants of it, and asks the question of where they belong in terms of this. What is really noticeable to me, even within our own organization, that with the current emphasis on ACOs and the contracts from CMS, that most care delivery systems think population health is beginning to work with more than one diabetic at a time.
So true.
That's really important, but it's not enough in terms of a vision if we're really going to get to health. And so the terminology, and again, Steve, thank you and your co-author for writing this in that paper, the background paper for NQF. The definition, the need for us to be thinking about how that plays itself out, and the definitions need to be clarified so that we have a better understanding of what belongs where, and the fact that population health, this term is not any longer useful enough. It needs to be total population health, as you suggest in that paper, and the subpopulations, the systems within the systems, sort of need to be thought through in terms of that. And so if we're thinking about metrics, we have to think about it at different levels, and they're going to be different. We've got a big conversation in the country about alignment and lack of burden, and sometimes that translates itself to sort of knee-jerk, same measure at every level. And I think that's not thinking that's going to serve us well if we want to serve your example, your individual example, as well as serve the national goals around population health. We have to have a much more sophisticated use, thought about alignment and measures and how they fit together. And we need to figure out and talk about where these kinds of behaviors fit, or where these kinds of factors fit with respect to population health if we expect to really have national policy that improves population health. So this is from that paper that you wrote, Steve, and your co-author for the National Quality Forum, and it really points out the system within the system approach of subpopulations and building up the total health population benefit. And it really, at least in this paper, talks about the determinants of health being a whole population kind of issue. I think actually, as a criticism in this paper, it actually too cleanly allocates it to the public side rather than not. I think in reality, there are linkages between the private and the public side that need to be thought through. So this is how we at HealthPartners have thought through it with our board of directors. This framework, you may recognize the general framework is the one that's proposed by the Match folks in Wisconsin, looking at healthcare, health behaviors, socioeconomic factors, and environmental factors, building up to health outcomes, and then primary drivers in the different boxes. And the conversation we had with our board was around which of these things were central to our mission, which we had capabilities and control, and which we had interest or shared capabilities. And so you can see in healthcare, since we're a healthcare delivery organization, that's central to our mission, many capabilities, high control. Health behaviors, we have shared capability. We have things we can do that are helpful to the public health group, and the public health group can be helpful to us. So we have a role to play in those. In socioeconomic and environmental factors, those are community identified and so forth. We are a large organization and have a citizenship in the community, and we have influence with the legislatures. Our CEO is a member of the Federal Reserve Board, Minneapolis, and works with many business leaders on issues around education and so forth. These are not issues that are of no concern to our organization, our community governed not-for-profit organization. So we have aligned our programs and our thinking around what we do in these areas and look for partnerships, not as a leader, but how we can participate supporting those things. We have thought about this, and this is you can't read it, but if you look at the slides closely afterwards, this is a preliminary sort of inventory of our different activities in the socioeconomic dimension. We have thought, David Kindig and I thought, that this sort of approach needs to be thought through by each stakeholder, and there needs to be thought through who has the primary lead and who has responsibility. So identifying new resources, here's a list, since my time is running, a list of possible ways of thinking about resources, and we need to have much more thought about how we resource community health improvement, and as well as how we think about incentives and how they're allocated in terms of creating incentives for the different parties to act. And then we finally get to measures. Okay, I haven't talked about measures yet, and my time's up, but the IOM says, and that's purposeful actually, because I think we have to think through these other issues if we're going to pick the right kinds of measures. So the IOM says that we don't really have a system, and we, as the planning committee, really talk through this multi-level approach and the fact that we've been grappling with the multi-level approach. And it occurs to me that we need to take this into account in our work, and we need to be thinking about what's relevant at each of these levels from the individual, and I did this before I knew what you were going to say, up to the federal or state level. So that's the challenge. Looking at the National Quality Forum, they have a concept I think that will be useful to us in terms of families of measures and core measures. And this is work that comes out of the Measurement Application Partnership. And they define families of measures as related available measures and measure gaps for specific topic areas that span programs, care settings, levels of analysis, populations, and so forth. And then core measure sets as available measures and gaps drawn from the families of measures that should be applied to specified programs, care settings, levels of analysis, and populations. And the reason that we have to develop this and use the map is because the federal programs that we're trying to help them provide comments to, there are 26 of them or more, and we have to think about, and they apply to very specific settings of care. So the federal CMS program for nursing homes, for doctors, for hospitals, and so forth, and we have to try to rationalize that. So the families of measures, what are the key issues for population health that need to be focused on, the key priorities? And then how does each of the settings, the hospital clinician and the long-term care in this case, or public health, private healthcare systems, and so forth, what are the things that they draw out of the things that are necessary to get the job done for that key issue? What's the responsibility of public health? What's the responsibility of primary? And those would form core measure sets. So that's basically the notion, and this sort of illustrates that. You did such a nice job of talking about individuals that I don't know that I'll spend a lot of time here, but basically this example shows how a person, a 65-year-old with heart disease in an ambulatory setting, would draw some measures out of the measure set for that setting. In the hospital, a couple, and then if they required rehab for some reason, might draw measures out of that. So is there an analogy here? This is very specific to the map work, but is there an analogy here to the kinds of ways we ought to use core measure sets and families of measures in our work in terms of the triple aim across these different levels that we need to work? And then just to mention that in the coming year, we have families of measures for 2 of the 3 legs of the triple aim, the work that's going to be coming up this year at NQF. And then a comment about cost. We have at HealthPartners, and Sue Knutson is here in the room with us, who's led much of this work, worked on a standard open architecture public measure of total cost of care. And the reason that's important is that we need to have, and you can look at these slides in some detail, we need to have a standard way of measuring. Every plan, government knows how to count its costs, but they're all different. And if we're to get to transparency and more public awareness of cost, we need to do it in a standard kind of way. And this, I think, represents a key opportunity. We're now working with Minnesota Community Measurement Minnesota to move this forward. That's moving along. And I think that, that this kind of thing is key to shoring up that cost leg of the triple aim. This, again, is the diagram that we use for our own clinics in terms of the triple aim. Relative cost of care, applying that cost metrics, and over time from 04 through 12 has shown that we've been able to reduce relative total cost of care in our market. Diabetes so far has been our proxy, for a very poor proxy, I would add, for overall health. But we have as an objective in our current strategic plan to develop a better way to comprehensively measure that. And then experience is measured at the top. So my summary, health systems and clinical and public health subsystems are complex adaptive systems. Undersigning and redesigning simple rules for the system and its subsystems may offer significant opportunity for enhancing desired population and individual triple aim outcomes. Clear and commonly understood definitions are needed. Explicit numeric goals should be set for the system as a whole and for the subsystems. Engaging each state and community across the country, as well as stakeholders at each level, needs to be a part of the national strategy. It can't just be numbers and regulations. It's got to be people that feel it in their gut, like a lot of people in this room, but much, much broader, much, much more people that needs to be engaged in this activity. Resources need to be identified, incentives need to be designed. A coherent national multi-level system of AAA measurement does not currently exist. This hopefully will move us toward that goal. We need standard total cost of care metrics for the system and subsystem. Quality needs to work as well. And the families of measures and core measure sets may offer us some concepts that may be useful. And transparency is critical. For the system and subsystems, we need to describe where we are. And more importantly, we need to explain the rationale for why this is important to the larger public. And that needs quite a lot of work if it's to be important and if we're to gain the resources and support we need for this work. So sorry to go over. Thank you.
So we're going to take the remaining time in this session and I'll open it up for discussion and questions and comments. And let me just ask everybody, when you're making a comment or asking a question, please announce who you are. That'll help with keeping records for the conference and let us keep notes. So thank you very much. Let's go ahead.
Are we getting up to the mic?
Sure, go ahead.
Hi, I'm Kathy Shane at the Commonwealth Fund. George, I had a question, and then it's a broader question as well. If I look at the two kinds of pieces of information you provided in the charts, one is that if we're dealing with factors that are affecting population health, there's a piece of it that's directly related to the healthcare system, but a lot is less directly. And then your metric of how you as a system have done on cost is relative to costs of care in the rest of the state. If we said that part of the reason that we're not doing as well as some of the other countries is the healthcare system parts pull so many resources out because it's so expensive that we're underspending on some of the support systems that are in other countries, whether it's long-term care. How does your cost experience look if you said relative to the growth of the state economy, so state GDP kind of, are you holding it constant? So if we said, what's our goal? Shouldn't we be trying to get the same or better outcomes out of the care system for the same or lesser share of the national economy so we can be freeing up resources to deal with the larger population? So I'm looking at those interactively, that, we don't have support in the home. We don't think about what happens to asthmatic kids if they go home to dusty houses, but we do give them inhalers, so we never had the resources to the other side. So it's the interaction, because your cost was just relative to the rest of the state. I think you're still going up faster
Oh, yeah.
than economic growth in Minnesota.
Exactly. And I think, thank you for really pointing that out. The real key, I think, to addressing the larger issues that you very appropriately point out is setting the national targets and really doing big thinking about what it's going to take to have us more competitive. And because that's re-engineering on a broad scale. It's social engineering that will require a level of leadership and governance that I really am worried that we don't have currently nationally. But it's the right kind of way to start thinking about costs. And this roundtable has really done a great job in terms of enumerating all the reasons and opportunities for cost, eliminating waste in the system. Our cost metric is a start to make total cost of care transparent in a market and to create a relative comparison. It is such a small down payment on the larger goal. It is so hard to do. And the chart I showed you is really using only HealthPartners data. And since we have such a large market share, it's a proxy for the rest of the market. And the work with Minnesota Community Measurement, hard work that's being done, will extend that methodology really to the whole state in terms of multiple data sources. But it is very hard to do because people don't want to standardize, and it's a down payment on trying to turn the competitive forces through transparency around in terms of the more I can charge and the more I can get away with. Nobody sees it, and that kind of dynamic. So you're very, very appropriate. Thank you for pointing out that that particular chart doesn't in any way really address the larger issue. But it begins to address a very critical issue in terms of creating cost transparency and competition.
Should we go over?
Gene Nelson from Dartmouth. Thank you very much, George and Maureen. Those are great presentations. And I think, George, you won the struggle in getting a great presentation. The issue of governance that Maureen brought out as being really tricky, and the integrator. And then the driver's slide from HealthPartners that you showed, George, is very much like the driver's slide that we would have at Dartmouth-Hitchcock. And one of the questions that we really don't have an answer to yet is how to have the governance structure and the payment systems aligned for health and healthcare so that it really works in a community and in a region. How to link the payment systems to the governance for the health and healthcare and expenses in the region. That's, in some senses, the elephant on the table that we're seeing and we don't have a good answer to yet.
Well, I certainly don't have an answer to that either. I've been struggling with that real issue of, first of all, whether or not you should have, an integrator. I hope this isn't heresy. And then I was on the IOM committee, the For the Public's Health, in the first report in that series that came out in 2010. In Chapter 3, we laid out a model for how that might be organized and led by public health. And I support that consensus committee. My own view remains that public health doesn't yet necessarily have the reputation or position in every community in this country to be that leader, although the folks on that committee overwhelmingly felt that way. And they certainly could be a leader, and I think there's a model there that could work. There are, and Maureen, you mentioned some examples, there are examples in our community of different leaders, both public and private, from public health as well as private, leading on different issues. And I just don't know how that gets done. I agree with your question. I don't have an answer to it.
I'll just add briefly that right now it depends on a visionary leader who is somewhat selfless about their organization to step in, because the financial incentives are so strong, especially right now, to optimize. People feel like we've got maybe a year or two left to optimize. And so we're in this kind of a trajectory of selfishness with respect to an organization. And I have the great luxury of seeing examples, particularly from other countries, where leaders have stepped out and said, we're going to do something that might not make financial sense on behalf of the whole. But it's what drives me to believe that if we don't measure all of the aspects of the triple aim, we'll never get the system fixed. So Jean, appreciate your question.
Randy Siebel, I come here sort of representing one of a few aligning forces for quality programs that are represented here today, and those programs have basically been inspired and formed in part by the Robert Wood Johnson Foundation's sort of vision that all healthcare is local. So first off, the focus on communities, I think, is key. I just want to make a quick comment about the integrator role, which I think everybody's thinking about a little bit here. The leads of most of the communities are the integrators within their communities. They are generally neutral conveners and sometimes leaders as well. They often will have the selfless, proactive, triple aim-oriented folks who lead them. The one sort of concept of the integrator that I've become familiar with recently has been proposed and put forward by Jania, and it's called the Backbone Organization for Collective Impact. He's published a few things in the Stanford Social Innovation Review periodical, and I think it's a pretty compelling argument about what makes for an effective backbone organization for collective impact. So it might be worthwhile reading.
I do agree with that. The work from Stanford on collective impact is describing, I think, very effectively what an integrator might look like, and I agree with all of their dimensions. Thank you.
So just a little comment on time. We're coming close to where we're going to need to take a break. Why don't we go ahead and finish up with the line of questions that we have here at the microphone, and then we'll be ready for a little break so we can make sure to move on to the next session. So Bruce, go ahead.
Bruce Ferguson, I'm one of the clinicians that Mike was referring to, and as a knuckle-dragging cardiovascular provider, I have a question for both Maureen and George related to the population issue. Is there a theoretical level of heterogeneity in the population beyond which the limits are stretched that you can't integrate things together? I am in an environment where, as a cardiac surgeon, I get referrals from all over the southeastern part of the United States, and I also get referrals from patients in Hyde County who have a single primary care provider for the entire county in eastern North Carolina. And I'm having a bit of a struggle trying to figure out how to squeeze all of this together into one construct. And there may be other examples, but that is a reality of the world that I know some of us live in out there as we try and figure out how to put this model into those kinds of environments.
I'll tell you, I am increasingly optimistic that we can design some models for a very diverse population like that. But I think what we've been doing is we've been designing by diagnosis, or we've been designing by financial utilization. And that, to me, I think we've been off the path. And we're at IHI doing a very deep research study into how do you create effective social networks. And we're learning so much about the segmentation process itself. So I'm optimistic, but we have a lot of work to go, I would say.
Yeah, I just told some people here, my wife just had her second hip replaced 2 weeks ago, and it was like my first opportunity to be out of a direct caregiver role. But she's had two hips done, two top-notch organizations with national reputations, and good results. And this last time, I was just so pleased to see that everybody was washing their hands. Everybody was washing their hands, and that we had direction in terms of education in terms of falls, particularly in the first day afterwards. And those sort of are opportunities to take issues on in surgical situations across the country, regardless of setting. And yet I was similarly impressed with how unique the surgical care was, surgeon to surgeon within the institutions and institution to institution. And I haven't decided myself whether that's like good or bad. I know that the result has been good first time, and I suspect we're on track for another great result. I don't think this sort of complex adaptive system approach relieves the individual of high skill and application of skills, and I would very much resist and be against the over-specifications I mentioned in my talk of detail where it doesn't make a difference. So the issue is hand washing and falls, and how do we lift out of cardiovascular care and orthopedic care much better than we do today the key elements that deserve that attention and leave the other elements alone.
I completely agree with that. My problem is I deliver the same level of care to the referral from Eastern North Carolina and to the referral from the southeastern part of the United States. The mortality of those two patient populations is double in the ones that go back to Hyde County.
Yeah,
and that's the reality. That's what we're struggling with.
Yeah.
That's where you're social.
Hello, Leslie Mickelson with Prevention Institute, and our focus really is on that, all these community determinants of health, and I've so appreciated that that's really on the table from the beginning, and how we address what the gentleman before me was talking about clearly has to do with those community factors. I wanted to put an example on the table that I think is one we're pretty excited about, which some of you may know about, the Accountable Care Community that's been formed in Akron, Ohio, run by Austin Bioinnovation, which is the integrator there, brings together, I believe it's 7 healthcare partners, and also 70, at this point, 70 community organizations. And I think what's so amazing about their work is that they're really looking at the dollars, and basically through initial efforts to reduce costs that really focused on better patient education of diabetics, they've shown the ability to pull some, through those cost savings, to pull some money out. And they have agreements of the partners to put that money into funding Austin Bioinnovation to do the community partnerships. And while a lot of their focus initially has been on better care coordination and higher quality care, they're looking at things like access to physical activity for low-income residents. And one thing that came out of the partnership that's very concrete is the local transit system agreed to offer free transit for community residents in a poor neighborhood to get to the national park in their county. So I think this kind of example is where we start to see that bridge, and I'm looking forward to how do we design metrics that encourage this kind of bridging and a real focus on changing community environments to support better health outcomes.
Great.
I'm David Stevens from the National Association of Community Health Centers and George Washington University. I'm asking this question to see because it might influence what we're thinking this afternoon. To what extent do you think we should be, for the use of the metrics or the suggestions for the metrics, that at least initially they help drive the local collaborations in the well, integrator might be too deep a word, but the people working together for the same aim. Because it sounds to me, listening to Maureen and George, that these relationships may be a precondition, not a result.
Right, exactly.
And so therefore, we may want to think of metrics as becoming more refined over time and extremely overly parsimonious, embarrassingly parsimonious, in order to recruit existing successful community and state collaborations and to be able to work better among ourselves, to get ourselves together before proceeding. Do you have any, first of all, does this relate to your own experience, and are there any other suggestions you might have that could help us inform this afternoon that if you think that is a true statement?
I love your idea, David, because as I put in a couple of the slides, the challenges of governance are incredible. Getting people, we found people didn't even speak the same language between the public health people and the clinical providers, and it took so long to get those governance situations to be vital. So I love the idea of driving the integration through a parsimonious set of metrics that are important and allow for local variance what's the most important thing for the segments of population in our environment. I think it's a wonderful idea.
I agree as well.
I'm Steve Toich with the LA County Department of Public Health, and thanks to you both. George talked a lot about where we sit on the healthcare investments and life expectancy. The other part of the report that he referred to on investing in public health talks about how we've chosen to invest in healthcare via all of the other sectors. And Kathy sort of brought up that discussion. But in fact, if you look at us versus the on an international scale, we invest about 8/10 as much in all of our social programs as we do in healthcare, and other countries invest about twice as much in their social investments as they do in healthcare. So that when, George, you were talking about standardization within HealthPartners as a great start, we need to begin to develop the standards to look at ourselves in a much broader context around the world. And Elizabeth Bradley, who provided those numbers, has begun to do that. But it tells us that we need to think much more broadly about how we're investing, particularly via those things that actually produce health in our country.
You know, one of the last slides to go out of my presentation was that one. I was also bold enough to suggest to Rob Sanders that he circulate your other paper to everybody in this group. So hopefully you'll get that too.
I have the great pleasure of working around the world and getting to watch the choices that nations make about where to make their investments. And I recently visited the healthcare system in Denmark with a group of U.S. executives who were trying to understand ACO structure and how does a group of healthcare leaders focus on health. And an interesting thing was doing a comparison between the approach, the social investment in care for women, maternity care. And so the C-section rate in Denmark is 22%, not quite. It's a little bit less than 22%. And when I asked them how they got their C-section rate down to that, because it was higher, they looked at investing in college tuition, because they said, obviously, we want women to have babies when they're at their healthiest, which is when they're young, instead of our system, which it burdens them with debt, so they have to go to work after college, which means they delay having babies until they're very older. But in Denmark, what they've done is they not only pay the tuition, and they pay a stipend so that the college students don't need to work, but if you have a baby while you're in college, they double the stipend, and they create social support. And I asked about the average length of stay after a normal delivery. Anybody want to guess? 4 to 6 hours. They said because clinical evidence shows that if you have a complication, it'll be before 4 hours or after 48. So before 4 hours, they have you in an intense little bubble of care, and then you go home, and at 48 hours, a home care coordinator comes to visit you, and that person is an RN with a bachelor's degree in 2 years of subsequent education, because they said it's so complicated to take care of people in their homes. But the whole system has shifted from investing in hospital care to thinking, using science to provide the best interventions at the right time in a person's life.
That's interesting. Well, Maureen, George, thank you so much for your thoughtful presentations, and everybody for the opening discussion.